Hello everyone, I'm Mert Öztaş. Today we are with Professor Benjamin Terrier from Colchan Hospital, Paris, and we will talk about his latest presentation in EULAR. So, welcome Dr. Terrier. What does your study add our recent knowledge in VEXAS syndrome?
Thank you for your invitation. So, as you may know, VEXAS syndrome is a new disease that was described by the NIH group in the US. And so the initial study summarized the data from 25 patients. So it's a very new disease for which we need some additional characteristics. And so the French cohort that was conducted by the newly constituted French VEXAS study group describes the data of 116 patients. It had that less than 5% were female, what was not described initially. So it can occur in female, and I think it's important to know. After, it helped to confirm some major characteristics that were made from the initial description, but it also points on probably important involvement, like the lymph node involvement that rates for maybe 40% of cases, and the gastrointestinal in 50% of cases, 15, and the peripheral nerve in 15%. So it adds some information about what could be the picture and when colleagues maybe should think about maybe VEXAS syndrome.
Yeah, thank you. And also a similar study from NIH, they also disclosed that M41V mutation was associated with worse prognosis. And does your result confirm this finding?
So, as you said, we can have different mutation. The methionine at the position 41 can be replaced, substituted by either valine, threonine, or leucine. What we observed in our cohort is that leucine, so the M41 leucine, was associated with a better prognosis. And the patient with the threonine or the valine seems to have the same prognosis. But I think the follow-up was maybe not enough. So we were not able to say that, okay, valine has a poorer prognosis, but we can say that it suggests that leucine has a better prognosis. So I think by accumulating data, maybe we would be able to identify some groups with different prognosis, and maybe it would help for the management of the disease.
Yeah, thank you. That's great. And also, your study disclosed that patients with myelodysplastic syndrome had worse prognosis. And does it change your clinical practice? Do you applicate more earlier human stem cell transplantation to these patients?
Thank you for the question. So you're right, so far, probably that the only treatments that can cure the disease is allogeneic hematopoietic stem cell transplantation. But usually, in our cohorts, the median age was 71 years old. So the majority of the people were not eligible anymore to human stem cell transplantation. So what the presence of myelodysplastic syndrome helps is that if we have myelodysplastic syndrome, it seems that as a cytidine, hypomylating agents are probably a good option. But if you don't have myelodysplastic syndrome, so far you cannot use in routine these drugs, and so the evaluation of treatments like biologics or ruxolitinib should be considered. And I know that the US colleagues from the NIH started a trial, and so maybe that in the future the presence of the UBA1 mutation would be like a high-risk mutation that will require hematopoietic stem cell transplantation when it's possible. But so far, you know, the number of cases that we treated, at the time we didn't know that VEXAS existed, are less than 10 in France. So I think it's probably a good option, but we have to get more data from the worldwide collaboration on that.
That's great. Thank you. Thank you, Benjamin, Dr. Terrier.
Thank you.